anemia of chronic diseases. Here the chronic diseases, may be of different reasons. For example, it may be due to chronic infection, due to chronic inflammation, or chronic neoplasia, or idiopathy, means the reason is not known. So, chronic infections like bronchiolitis, anemia of chronic diseases can be common, and chronic infections like rheumatoid arthritis, SLE, and neoplasia like Hodgkin's lymphoma. So, these are the conditions in which we can observe anemia of chronic diseases. Now, let's discuss pathogenesis of this anemia of chronic diseases. For example, there is chronic infection. So, because of these chronic infections, release of cytokines interleukin 1 and interleukin 6 will take place. So, interleukin 1 and interleukin 6 are the most important cytokines, and in these both interleukin 6 is very important. Okay. So, because of the chronic infections, there will be release of cytokines like interleukin 1 and interleukin 6. They act on the liver. Because of this, we already discussed that regulator of the iron is hepcidin. Hepcidin synthesis will increases. Because of this increase in the synthesis of hepcidin, the two pathways will take place. First one is the normal one, like if hepcidin increases, it degrades the ferroportin. So, iron will not come outside and serum iron levels will decreases. So, it leads to the microcytic hypochromic anemia. Okay. And the second one is CFU erythroid. And the second pathway is these hepcidin will affect the colony forming unit erythroid, because of which RBC decreases, and RBC is getting decreased, but there is no change in the shape of the RBC. So, it will be normocytic, normochromic anemia. Okay. So, these are the things that you should remember. In chronic infection, cytokine 1 and 6 are getting released. They acts on the liver, because of which hepcidin increases. These leads to defect in the two pathways. First one, it degrades the ferroportin. Second one, it affects the colony forming unit erythroid, because of which we will get anemia. First one is microcytic hypochromic anemia, and the second one is normocytic normochromic anemia. Okay. Now, let's discuss about the investigations. So, what are the investigations you are doing? So, first one is CBC. In CBC, you can observe hemoglobin, total leukocyte count, platelets. So, hemoglobin decreases, TLC and platelets will be normal. Second one is peripheral smear. Peripheral smear will shows two kinds of cells. First one is normocytic normochromic anemia. Sometimes microcytic hypochromic. And third one is iron profile. In iron profile, you can see serum iron getting decreased, serum ferritin will increases, because storage of iron increases, but it is not released. Storage is increasing but release is not increasing. And serum total iron binding capacity will be decreased because as the iron is low, serum iron is less. As iron is absent here, its value will decreases, but storage iron is overloaded, but the release is not up to the extent. So these are the investigations, and the next one is we can also observe, and the last one is soluble transferrin receptor assay. It is nothing but the component which is useful to differentiate between the iron deficiency anemia and anemia of chronic diseases. For example, if soluble transferrin receptor assay is less than 1.5, it implies anemia of chronic diseases. If it is greater than 1.5, it is iron deficiency anemia. So, what is the difference between this? In anemia of chronic diseases, the liver is getting affected, because of which hepcidin will increases. As hepcidin is increasing, the iron absorption will be normal. For example, this is duodenal enterocyte. Iron is absorbing into the cell. So, this hepcidin will affect the enzyme, that is ferroportin, present on the basolateral membrane of the enterocyte, because of which the iron is not coming out. Okay. So, iron storage will increases. Hence, serum ferritin is getting increased, but iron is not coming out so that it can produce RBC. So, it is absorption is normal. So, storage is also normal, but utilization is defected. So, serum iron level is decreasing. So, that is the difference. In iron deficiency anemia, the uptake is low, or uptake may be low, or demand may increase, or absorption may be low. But because in these three conditions, iron is not entering into the body, whereas in anemia of chronic diseases, iron is entering into the body, but because of some cytokines like IL-1 and IL-6, liver is getting affected and the pathway is getting affected. Okay. So, this is the difference that you should remember to differentiate between the iron deficiency anemia and anemia of chronic diseases. And the most important factor that you should remember is soluble transferrin receptor assay to the log serum ferritin. It gives the difference between these two. And you must remember Menzer index. In this, if it is greater than Menzer index, this is MCV by RBC. If it is greater than 13, it implies iron deficiency anemia, and if it is less than 13, it implies that it is thalassemia. Okay. So, these two are very important to differentiate between the iron deficiency anemia, thalassemia and anemia of chronic diseases. Okay. And in anemia of chronic diseases, you must treat the cause, because the cause may be, if it is infection, you must give the treatment that is related to cure the infection, and if it is neoplasia, you must give the relatable treatment, and if it is infection, you must take care of that infection. Okay. So, these are the things that you should remember in the iron deficiency anemia. So, this is all for today. If you not yet subscribed to the channel, please consider subscribing to the channel. Teddy guides you. This is K. Harshita signing off. In the next class, we will deal with the upcoming anemias.